Hello, my name is Professor Mohammed Muhtaseb. I'm a consultant ophthalmologist in the United Kingdom in South Wales and a visiting professor of ophthalmology at the universities listed on the slide. I'd like to thank the great team at BVI for inviting me to give this talk about how to be a superhero for your patients. I don't know who that guy is, but you don't see us both in the same room at the same time. So what's the job of a cataract surgeon? Well, is it to do lots of surgery, to do great eye surgery? Is it to use fantastic equipment, to do research and publish, or is it to teach juniors? Or is it in fact to build a successful practice? When in fact, the role of a cataract surgeon primarily is to make a happy patient. Now, how can you do this? You do this by giving them what they want, and you do it by not giving them what they ask for. So, if a patient wants multifocal lenses, what you should hear is, I would really like to be able to see after surgery without the need for glasses. Now, how can this be done? Well, first of all, you have to ask the right questions and listen to the patient's replies. It's very important indeed to interpret what they're saying. So, are they asking for something that you can deliver in a different way to the method in which they're asking for it? And then you have to ask yourself, how can I know that I've done a good job? And how can you keep improving? And you do this by keeping a log of your activity, your clinical results, the objective outcomes, and the subjective outcomes thereafter. And this is how you get happy patients who've had radial keratotomy, very distorted corneas, and dense cataracts. So what are the top tips for getting a really good result after cataract surgery? Well, you can see them listed here. First, meet the patient's objectives and expectations. It's very important to establish previous relevant ocular history, including, for example, refractive surgery by laser vision correction or radial keratotomy, using the most up-to-date biometry, and use appropriate biometry with topography if needed. Use the most up-to-date lens formulas, including Barrett family, Kane, Pearl DGS, and so on. The astigmatism is crucial. So for premium lens implants, it's critical to minimize the postoperative refractive astigmatism. So understand your surgically induced astigmatism, where the incision is going to be located. Do you sit superiorly or temporally? The initial or most common thinking about, well, I'll treat astigmatism of over half a diopter or 1 or 1.5 diopters is not the right way to approach astigmatism. The thing to manage is the expected residual astigmatism after the surgery. So are you going to induce astigmatism? What's the expected postoperative astigmatism? What kind of lens are you implanting? And manage that accordingly. Use all the armamentarium at your disposal. So whether that's mini monovision or micro monovision with an enhanced monofocal or monofocal plus lens, or an increased range of focus lens, or a full range of focus lens after full discussion with the patient, the entire range of lens implants, refractive outcomes, and binocularity with mini monovision or micro monovision is absolutely crucial. And then you have the biometry machines. So I'm happy with the different biometry machines and use the one that's most appropriate to your patient and your clinical practice. So in terms of astigmatism management, know your own surgically induced astigmatism. And there are online surgically induced astigmatism calculators that can help you manage that. But whichever way you calculate your own SIA, it's important to do it and to understand the results of your surgery in order to plan for the post-operative astigmatism. And I always tell patients that we are dealing with the astigmatism that we expect them to have after their surgery using measurements taken before their surgery, because patients who maybe haven't heard of astigmatism or don't have it will ask, why are you talking about astigmatism? And sometimes patients will say to you, I have astigmatism, why are you not treating it? Then you have to explain that the incision may relax the cornea in that meridian, and the expected post-operative doesn't need to be treated with a toric lens. And so managing these outcomes is very, very important. And you can see here that as a basic guide, you should assume that the posterior cornea adds 0.5 diopters at 90 degrees. And there's our superhero making his entrance into the equation once again. And that's just topography to show the posterior cornea. So do not treat the preoperative astigmatism. Manage the expected postoperative astigmatism and keep it below a half wherever it's possible, and certainly for premium lens implants. With monofocal lens implant patients, they will be quite happy, and you don't have to really push for astigmatism very hard if it's going to be less than 1 diopter. If the incision's at 90 degrees, then the SIA is going to be -0.5 at 90, with the posterior cornea being -0.5 at 90. So you should assume that the postoperative astigmatism will be -1 compared to the preoperative keratometric astigmatism. Whereas if the incision's at 180 degrees, the posterior cornea is +0.5 at 180, the incision is -0.5, so the incision is astigmatically neutral. And now you are well on your way to being a cataract superhero. This is ClearLog, which is a software which I'll come to later, available on the App Store and on Google. Now, this is my toric lens use between 2019 and 2022 at the top, and between 2022 and 2024 lower down. So you can see the toric lens use has increased. Discuss all IOL types with your patients. So again, like I said, manage the expectations, advise them of all the possible treatment options, even those that you're not going to perform. So tell patients who've got macular degeneration about multifocal lenses and why you're not going to use them, because they may have heard about multifocal lenses from other people and will wonder why it wasn't offered to them. So you can use monofocal, enhanced monofocal or monofocal plus, increased range of focus or EDOF, however you want to term it, and full range of focus or multifocal, bifocal, trifocal, panfocal lenses. You have to discuss the refractive outcome. Are you going to aim for emmetropia? True monovision, which I personally don't favor, but if someone has a long history of monovision in contact lenses and they're happy, then that's okay. Are you going to talk about mini monovision with a mono plus lens, or micro monovision with an increased range of focus lens? Now, be a superhero to yourself as well as to your patients. Make sure that you do the job that you know you can do, but protect yourself. Document everything. Document what you say. Document what patients ask you and your replies. Document the discussion about surgical risks and benefits, including the risks that are specific to each eye, not just a generic risk that you say to every patient, but risks that are specific to every particular eye. The right eye may be different to the left eye in a given patient. Document what you say about the risks and benefits of the lens types and the refractive outcomes that you've discussed and offered. Provide written information to the patient in plain language that they can easily read and easily understand. And finally, document your plan. Make sure that you document what you're going to do, which eye first, which lens you're going to use, the refractive outcomes for each eye and the binocular refractive outcome. Document it and give the patient a copy of the plan to read. So case 1 is a 72-year-old female with reduced vision in both eyes with prior good vision with glasses. Both eyes were previously seeing well, and she wanted excellent unaided near vision post-op. She'd already seen 2 surgeons, and there was difficulty in measuring the keratometry readings on the IOL Master and various other topography machines. One surgeon said not to use a toric lens. Her unaided distance visual acuity, you can see in the right eye, was very poor, best corrected when it was 6/15. Left eye was even worse. Dense cataracts in both eyes, so we discussed all options, including the accuracy of biometry and the refractive outcome. We talked about monofocal IOLs targeting myopia, or an increased range of focus lens targeting myopia, and we selected that option. So this is her Aladdin biometry scan, and that's the lens we were going to use for the right eye, and you can see we were targeting -2 diopters. It was absolutely crucial to her that she could see unaided to read. So we had to nail that. And that's the biometry for the left eye, also targeting just under 2 diopters. So postoperatively, unaided was 612 in the right eye and 69 in the left eye. She was -0.5 in the right and plano in the left. Thank goodness we didn't target -0.5, but these is keratoconus, and keratoconus biometry can be variable. And her unaided was, as you can see here, N3 binocularly, so absolutely overwhelmingly happy. The other was a 78-year-old female seen by an oculoplastic colleague just across the corridor when I was in my own clinic. So she came across and knocked on the door and said this lady who'd had a lower eyelid operation wanted cataract surgery and wanted multifocal lenses. Now, the patient had blepharitis, dry eye with a short tear breakup time, 3 millimeters of lag ophthalmos. She had inferior punctate epitheliopathy, and she had retinal pigment epithelial change of the macula. So there was no way that this patient was a candidate for multifocal lens implants, but that's what she wanted. But when a patient says, I want multifocal lenses, you hear, I would very much like to read without glasses after surgery. It doesn't matter how you do it, as long as you do it appropriately, safely, and can deliver the results the patient's expecting. So we discussed all the options, and we decided to go with an increased range of focus lens with micro monovision. We used the Vivity. There are other options available, and certain monofocal plus lenses would be appropriate for such a case as well. So the right eye targeted emetropia, the left eye targeting minus 0.6. And at 4 weeks post-op, you can see here from the results that she is binocularly 6/7.5, unaided near is N4, and her refractive outcome is very, very close indeed to the target. So give the patient what they want. Doesn't have to be the way they're asking for it, because you're the expert. Now, how do you know that you're delivering what the patient wants and what you're trying to achieve? This journey doesn't stop when you take the speculum out of the eye. This journey carries on because you want to turn an unhappy patient into a happy patient. So you need to log your cases, analyze your results, and make sure that you're achieving what you want to achieve. Now, there are different ways of doing this with EMRs and expensive systems and various other options. I'm going to talk, just for the limited time I have left, about ClearLog, which is a software that I've developed. It's free to use, and it's available online on a URL or as an app on Android and Apple. So it provides a detailed analysis of your practice and your objective and subjective outcomes. Best news is it's free. So there's a URL, you can scan the code and go to the website and download it by pressing the buttons at the bottom. But there are areas where you can enter data and analyze your outcomes. The data I'm going to show you now are made up. These are from the demo mode. You can go to the demo mode for free, try it for a week, add in data if you want to, and it'll all revert to the way it started after 7 days. So what I'm going to show you now is not real. So this is simple mode. If you're just interested in posterior capsule rupture, refractive outcomes, cumulative visual acuity, and endophthalmitis rates, there are just 2 screens, and you can enter the data for both eyes on the first screen and the follow-up on the second screen. Simple mode allows you to look at the standard reports only, which are listed here. So these are the basic quality parameters. On the app version, this is just to show you how quick it is to record and analyze your posterior capsule rupture rate. It defaults to a year. You can change this to anything you like. So this is going to be 4 years of data. Generate a report, and you can email it to yourself. On a computer, you can download a JPEG. So these are some basic analyses which include posterior capsule rupture rate, which is classified by risk complexity of your case mix, refractive outcomes with plus or minus from target refraction. Here you have cumulative visual acuity, and then moving on to custom reports where you can choose 2 of the data entry fields and then a filter. And so you can get multiple levels of analyses onto one graph, including the IOL types that you use, the outcomes over time, the case complexity, the different lenses that are used, the patient satisfaction, and so on. So here is IOL types and halo frequency, and you can see which IOLs are producing halos never, some of the time, all of the time, and so on. With the analysis of y-axes, you can have one y-axis and have 3 lenses analyzed on one graph with one parameter, like uncorrected acuity for distance or for near, or halos, frequency, severity, and so on. Or you can have 2 y-axes and analyze one lens. So you can have one lens and analyze 2 parameters. So for example, unaided distance and near acuity, or visual acuity and satisfaction. And you can compare the graphs over time and different lenses on a single graph. So these are more examples of outcomes over time with visual acuity and halos, for example. More examples of how to analyze these reports. And so what do you do with this information? Well, data is king. You can do what you like with the data. Firstly, in the UK, you can appraise and revalidate. Secondly, you can give your information, your data to your patients with evidence. to your referral base with evidence to back it up. You can benchmark your results against national or international outcomes and published data, and you can drive your practice forward. You can find out very easily the things that you're doing that are making people happy and the things that you're doing that are not working so well, and change your practice accordingly. And finally, patient counseling and informed consent and marketing. You can use these graphs in presentations such as this, or in published papers for peer review. You can download them and insert them as JPEGs. And finally, laser log is on the way. So laser refractive surgeons will be able to use a laser refractive version of this by the end of September or early October. And now you are a true cataract superhero. Congratulations. Well done. Thank you.